And thanks everyone for coming today. I'm really happy to be here. Yeah, so today I'm basically talking about fire implementation at the Michigan Public Health Administration. The first half, I've got about a dozen slides. The first six are kind of introductory slides in context, and then the last six are basically kind of like the middle of the story in a way. So I guess I should tell you now that I haven't figured out the end of our story yet, which is part of why we're here with FHIR, is figuring out, like sharing what you're doing with the community and then trying to figure out how to actually, you know, align as much as possible with other people's work. So I am Cindy Throop. I have a master's in social work. I focus on policy, research, evaluation, data, that kind of thing for both social policy and health policy. So currently I'm a fire data scientist at the CDC Foundation. I'm part of the Workforce Acceleration Initiative, which is a multi-year, maybe like a 2-year max funded project. I'm assigned to work specifically with the Michigan Department of Health with their public health administration. So a little bit about the people that are bringing me here. So the CDC Foundation, that's the Centers for Disease Control Foundation, is a nonprofit authorized by US Congress to mobilize philanthropic partners and private sector resources to support CDC's critical health protection mission. So it's not CDC, it's a CDC Foundation, but we're kind of related. We're like cousins. And then the Workforce Acceleration Initiative, that's a subset of funding that is hired. There's about 100 people like me, like 120 people roughly, and we're assigned to health departments around the United States, either at local, regional, or state level public health agencies. And we're helping them by providing technology and data expertise that they need to accelerate their information system improvements. And as you may or may not know, in the United States, most of fire implementations are in regular healthcare. So public health is very much behind, and it's kind of like the equivalent of a lower resourced environment. So they definitely need help. And then the Michigan Public Health Administration, like I think I said, is the Michigan's state level public health agency. It consists of a number of bureaus, including Bureau of Labs, Epidemiology and Population Health, and also infectious diseases. Also, there are other bureaus. I can't list them all. And then the state of Michigan is also leveraging another stream of funding called the Public Health Infrastructure Grant. So there's actually about 12 of us focused on different things that are all working together to help Michigan essentially modernize its IT infrastructure. I'm specifically focused on fire. Other people focus on different things. So Michigan, if you're familiar with vital statistics or death reporting, you may be familiar with Jeff Duncan. He's our main champion for that kind of work. And sadly, during the COVID-19 pandemic, we had a lot of deaths to deal with. So the process of completing death certificates, that whole process and how painful it was became even more painful. So there was a need to basically increase efficiency. So that was basically Michigan's first fire project. So Michigan utilized federal funds to create a fire-based interface for coding death certificate data. We leveraged the vital records death reporting guidance from FHIR for supporting bidirectional exchange of mortality data between Michigan and the National Center for Health Statistics. So for people not familiar with death certificates, we basically were reporting the fact of death data to NCHS and then getting back ICD-9 codes for the cause of death, which you need to have both the fact of death and the cause of death to complete a death certificate. In terms of other projects, there's a lot kind of in the works. We're talking with a lot of different people about doing different projects, but the Bureau of Epidemiology and Population Health is the most advanced. They've done the death data, some stuff around death data, birth data. They're doing some work around birth defect data. I believe they're using Smart on Fire for that. For the Bureau of Infectious Disease Prevention, they're looking to move to FHIR for exchanging electronic case reports. So they're in the process of procuring a vendor to help with that. And last but not least, in terms of projects that are like officially active, you may have heard of the Flint water crisis, the lead crisis. A number of years ago, they switched water sources and it, via some kind of chemical process, released a bunch of lead into the water system. So people in Flint have been very much affected by that. So what has happened is Michigan has made it a legal requirement to test all children at ages 12 and 24 months for their blood lead level to see if they need to be treated. So that's something that we're using FHIR for, that we're working with our state HIE to implement that project. In terms of lessons learned, some of these lessons were learned before they hired me, and which is kind of why they hired me. But they basically were wanting someone to help coordinate across bureaus and develop a strategic plan or a maturity model. Obviously, I guess the lessons learned is a little bit redundant, but you have to actually document your lessons learned to know, to basically be able to learn from them and like share from people and not have each bureau kind of make the same mistake that the bureau next door made. So basically what I'm doing is coordinating with various stakeholders, including the bureaus, which work in silos, our centralized IT entity, which for the state of Michigan covers like everything for public health, health and human services and everything. So it's a very centralized and, bureaucratic IT infrastructure, which makes implementing something like FHIR very, very challenging. We also work with our state HIE, MyHIN, and we also need to be connecting with other public health entities, which is why, we have representation at this conference. We want to make sure that as we're figuring out things like how to represent blood lead level data, that we're coordinating with other people, because we could define it however we want, but we want to make sure that it's that it can be mapped to other data, because you don't want to have a bunch of one-offs. It defeats the point of standards. So to that end, I have pulled together a maturity model that we're getting feedback on. No one hates it so far, which I guess is good. For FHIR, there's the technical aspects. I have a slide for each of these 4 items, so I'll go into each one separately. For the FHIR aspects, we're still kind of figuring out what this is going to look like. I started with some basic assumptions in terms of we're moving from paper-based systems to automated systems, and it's not like you go from 0 to 100. Something might be 5% automated, and you want to move towards an entire process being maybe 20% automated, and obviously, in an ideal world, you would have everything automated. One key assumption is that FHIR is better than paper. I feel like I'm playing rock, scissors, paper here, but FHIR is better than paper, which is another way of saying that moving from CDA or V2 to FHIR is just not as critical, because we're using CDA and V2 in the state of Michigan. It's working fine. Why mess with it? In terms of measuring advancement, we're looking at the number of use cases, the complexity of use cases, and of course, we're trying to optimize best paths forward, which is kind of challenging because we have the different silos and we have different subject matter experts in each silo. And it's hard to come up with a single plan. Like right now, we've got 3 things that are basically out the door and they're all going in 3 different directions. I think that they're hoping that I can magically help them have a cohesive plan. And I'm realizing that it might not happen quite like that. I think it's just about kind of managing the chaos at this point and just learning from what we're doing. To that end, this software development capability maturity model people might be familiar with, but I wanted to emphasize the second part, which is that the process is repeatable, that the process is at least documented sufficiently such that repeating the same steps may be attempted. With FHIR, we're just not far along enough to have standardized steps. So that's something that we're kind of trying to help the centralized IT people keep in mind, that this isn't about picking like a vendor for everything. We're still learning as we go along. And then for stakeholder collaboration, this is actually something you can measure. People talk about collaboration all the time, but they don't really know how that word is defined. So like the first step towards collaboration is networking. And that's basically just meeting someone and, wondering or knowing, like, who are you? What are you trying to do? The next level is cooperation, where you realize that, oh, we have things in common. Maybe we could work together on something. When you get to the level of partnership, you've built trust. You've already worked on one project. So you decide that you're going to work on more projects together. For coalition, we're sharing, resources and thinking about doing a multi-year plan. And then collaboration, which the word people overuse, is where you've built interdependent systems to accomplish a shared vision and meet key benchmarks. And then the last of the four is workforce development, which has to do with the source of the funding for my position. But the challenge in Michigan is that there's an assumption from the centralized IT infrastructure that pretty much 100% of the technical expertise comes from that centralized entity. But FHIR is a very different thing. And I'm not sure how much people realize that FHIR standards are, evolving and being developed. And it takes people, actual public health staff need to be helping and working with the public health and FHIR community to figure these things out. We can't have a centralized IT group do everything for us. So, and I also wanted to acknowledge that there's layers and types of expertise. Basically, the kind of stuff I'm doing is more like managing the cross-unit collaboration. And then there's also like, this is Dev Days. We've got a lot of technical people, developers, and then there's people who have both levels of skills. And I'm just diving in a tiny bit on the work streams that we've come up with to support workforce development. So basically people can dip in or out. And this is basically my audience here is public health staff across all the different bureaus within Michigan. So we're basically pulling together introductory FHIR resources, which are available widely, thanks to HL7 and other people. We're basically leveraging existing resources and adding what I call like a public health window or introduction to it, because a lot of the resources are more aimed at healthcare people as opposed to public health people. And then we've also got some intermediate work planned where we're going to be doing some experiential learning exercises with people, like pulling together people from different bureaus and walking through our past and current FHIR use cases. Because if we kind of walk through what we did a few years ago for the death reporting and then start walking people through what we want to do with the blood lead level testing, people are going to realize that FHIR, like the FHIR standards around death reporting are more developed. There's an implementation guide. There's a lot out there. When you're starting with something like blood lead level data, which I don't think anyone specifically has mapped out yet, you're starting from a different place. So kind of trying to get people to understand that your entry into the world of FHIR depends on your actual use case, and it's not going to be the same experience every time. And then let's see. And then last but not least, the advanced work stream is basically, the idea was not for me to come into the state of Michigan and tell them how to do anything. The idea is to build consensus around like what is Michigan's FHIR strategy. So we want people to be able to participate in those conversations and obviously plug people in to the national kind of FHIR or international FHIR work. So, and speaking of collaboration, I'm interested in collaborating with people from other public health departments or perhaps European kind of public health in terms of comparing notes. We want to make sure that anything that we're doing is aligned and building upon existing work. So I'm going to leave that slide up for a minute if people want to take a picture or whatever, but we can move to Q&A at this point.
Questions? No?
Hi, thanks for the talk. Very interesting.
Thanks.
Would you be interested in sharing your FHIR maturity model? Because we have a digital maturity assessment in the UK, but and we have some questions around standardization, but not specifically FHIR related. And I think it might help to understand.
Yeah, we're more than happy to share because I mean, my position is funded by like a national kind of agency. So we're hoping that whatever I develop for Michigan can be used more broadly. So yeah, I'm definitely happy to share what we have with you, the different dimensions. You can kind of like pull out what is relevant and what's not relevant. But yeah, let's talk.
And maybe following on from that, I guess you touched on it in your talk, but can you expand on how difficult it is to actually think of next steps for organizations or health agencies if they're at a particular step in their maturity, how to increase that?
Well, it obviously depends where you're at. And the reason there's so many dimensions to this maturity model is because as we keep hearing is that technology is the easy part. It's people that are the harder part. And that's why I added the collaboration framework part in, where you can kind of like measure what that looks like. But you literally, you tend to have organizations where people, they can't figure things out. And then you realize, well, they haven't even talked to each other. No one's actually introduced them to each other. So the maturity model kind of offers like next steps. So depending on where you're at in that model, and you're like, oh, they're not collaborating, it's because no one's ever officially introduced them, like people within the same organization. So it just starts with like informal introductions or formal introductions and having people explain like, what do you do and what are you trying to accomplish? So yeah, so your next steps really basically depend on where you're at.
Thank you.
Thank you.
I have a complex question.
Oh, awesome.
You talk about blood level of lead. Oh.
Time's up. Sorry, I don't have time to answer your question, Diego.
So I'm old, and I remember one V2 implementation guide, which was for lab reporting to public health, and it was mandatory in meaningful use. So it's mandatory from 2008.
Right.
Can you just tell the labs, when you have a lead, also send me the lead level?
Well, absolutely, but we need to get into more detail because, like, because we don't want to know. It's not like a yes/no question.
It's not just the level of
Well,
lead.
we want to know what the actual blood lead level is.
Or you want to also tell the clinicians to remember to order the test.
Right, because we need to know, like, has this 12-month-old or 24-month-old, have they ever been tested? So they need to know, like, yes.
So it's
or
more
no.
about the asking.
So then they have to be tested, and then once they're tested, then what was the result? Do they need treatment? And if they need treatment, then you want to make sure the treatment works.
Oh, you want all the pipeline.
So it is. I mean, yeah, that's what we're going for ultimately. Is that? And then you have to look at, like, there's like the WHO guidelines, there's CDC guidelines, and then there's the specific guidelines and measurement cutoffs that are written into the Michigan law. So you have to kind of figure out, how do we accomplish what Michigan needs to accomplish, but also leave it open enough that people from other states or other countries
There are
could
no
maybe
other
use
states
that.
doing the same right now?
Not that we know of. So
Okay.
yeah,
Nice.
that wasn't that complex.
No, but it serves me to understand the use case and what you need overall. Not just
Yeah, we still have to think through all of that, obviously.
the first thing, that if you need just the result, just get the result. But if you need
Right.
if you need to tell them to order the test, that's another
Yep,
more complex,
yep, absolutely.
because that involves maybe Smart on Fire app in their EHR. The EHR needs to support that. You need to be able to intervene the EHRs. That's a lot
Right.
of,
Yeah, it's a little bit, yeah, it sounds kind of easier than it is,
No,
like,
no, it's
like
not.
most things. But then you kind of realize there's all these workflows and decision points, and how do we make that work using FHIR?
no more. You can go to have lunch.
Thank you.
Thank you.